Pam, at the meeting in San Augustine, which we just recently attended, you were telling me something that really piqued my interest, and I didn't have time to follow up on it because of the meeting. But I have a grandson that is 8 years old. He's he's a small child. He hadn't grown yet. He hadn't even lost all of his front teeth. But he has night terrors.
Mhm.
And you were telling me about a case with night terrors in a child. And I know many people out there listening, every parent, every grandparent either has a bedwetter or night terrors. So let's dive deep into that and what's going on with these poor children.
So we know for a fact that when we breathe through our nose within the perinasal cavity, the sinuses, when we breathe in, the epithelial or endothelial cells, meaning the lining inside there, takes the oxygen we breathe in and creates something called nitric oxide. And then the nitric oxide is released into that same airflow and goes down into our lungs and goes through our entire body. Why is that relevant? Well, nitric oxide is extremely important for many reasons. One is cognitive health of children that are developing, so it affects their how quick they're learning, their memory retention, long term, short term. It also affects the vascularity, so the way the blood flow goes through our entire body that feeds all of our muscles and organs. Um, so it's very relevant and the way it impacts kids during sleep. So let's say, for example, a child has some kind of obstruction and they're not nasal breathing, like they have swollen turbinates or an adenoids that we talked about in the past, but they are constantly mouth breathing. And the tongue is also crammed back in the throat. So they're not getting any good air coming in and no nitric oxide being exchanged. As the body is constantly suffering, many things are going wrong. One, the heart starts beating really fast because the brain is telling the heart, beat faster, because I'm not getting enough oxygen in. There's too much carbon dioxide in the body, beat faster. But there's a true obstruction there. So the heart starts racing. The mind's not getting the cleansing that it needs. So we start getting nightmares or night terrors. So all of these things are our body's way of kind of jerking us awake again. So we wake up and we can breathe, maybe not completely awake, but they roll over so that it opens up their airway or they do something to knock their head back. So when we can't breathe properly through our nose, that's what's causing the kids to have night terrors. The minute we get the kids breathing through their nose and the lips sealed, that's the first thing that goes away. And this shocks parents. I mean, parents come in crying like this boy, Matthias. He was happened to be 8 years old, same age as your grandson. And I met his mother when I was teaching at a dental hygiene society in our area. And she didn't tell me anything that day. She didn't come up to me, but she shows up in my practice with her son. And she tells me the story like, my son, super quiet. He was not verbal at all, didn't say anything, very shy, but wicked, like just attentive in some ways. So she's like, my son, for us to sleep with him, he sleeps in bed with us still. An 8-year-old who sleeps in bed with his parents still, because they have to prop him up on 4 or 5 pillows and not just up, but side to side. Because if he lays back at all, he starts gasping for air. It's gotten so bad that the boy is terrified to fall asleep. So it just got worse from nightmares to night terrors. So now he doesn't want to even go to sleep. Imagine that impact on that child's day-to-day function, right?
Now, didn't that child say something to you about being terrified to go to sleep because he may not wake up?
Yeah, that was a tough moment in the office because I was like, why? His name is Matthias. I'm like, Matthias, why are you nervous about going to sleep? Why do you not want to go to sleep? And he said, he goes, I'm scared I'm not going to wake up.
Oh, that's just horrible. Yeah. Oh, so okay, let's dig pretty deep into this. So you're talking about obstruction, and obstruction can come from no air going through the nose, going through the mouth, correct?
Correct.
If it doesn't go through the nose, it doesn't go through all the biological things that are necessary for the body to operate correctly.
Correct.
So there also can be an obstruction of the throat,
Hmm.
and that is when an apneic event occurs. And I have never dealt with children in a sleep study. So this is new information, unknown information to me, not new. And so the children also have apnea where they're not getting any air at all. Is
Hmm.
that correct?
That is correct.
Okay. So I do know about when the airway is completely plugged, mouth and throat, that the body starts dumping out hormones. One of them being cortisol, and there's a lot of epinephrine and things like that. And what is really interesting is that you can put a patient on a pulse oximeter. That's the thing they clip onto your finger, when you're going to the doctor to read the oxygen level. You can put that on an adult, and I don't know about a child, and you can have them hold their breath, and the oxygen level does not go down. So, in an apneic event, if that throat clogs, that oxygen drops immediately. That's what dumps the cortisol. That's what dumps the hormones in. And if they repeatedly have this over time, then that is is horrible to the body because the body they can't recover from the breast stop and the chemicals and hormones being created. And so I can see why these children need to sleep with their parents. They need protection. They are going to think they're going to die.
Well, think about all the kids that are, being misdiagnosed with ADHD. If, like everything you just said, imagine having like elevated levels of cortisol in your body. So these
Right.
kids are either a little bit edgy or hyperactive. And then on the flip side, they're not getting great oxygenation to the brain or nitric oxide developed in their body. So they're kind of like dopey or a little slow sometimes. So these kids end up being, typecasted as the troubled kid or the slow one. And a lot of times I think even these kids are being misdiagnosed with mild versions of autism when all they need is the capacity to breathe through their nose so their body can function. We get it with adults. Like, okay, if I don't get any sleep, I'm going to be cranky and not function well,
Yeah.
right? And then when you're sick, when your nose is congested and your mouth breathing all the time, you just feel kind of slow and dopey, right? And these
Right.
kids are like developing radically and they're not getting what they need to the body at all. So, of course, they're not going to function normally like the rest of them. One other thing, you brought up the whole bedwetting thing. Why do kids bedwet? And um, in adults, it varies. And I want to talk about that a little bit too. So again, child is not breathing. They're having an apneic event. Okay. The blood flow goes to the midbrain. The midbrain measures carbon dioxide, not oxygen. And when an elevated carbon dioxide levels are high, it signals to the heart, pump faster. Well, the nerve that it's signaling the heart is the vagus nerve. And the vagus nerve does a ton of things, including innervates the diaphragm and the bladder. So what happens, it's just again a body's mechanism of protecting you. The body will do anything for the ability to breathe. So it might wake you with a terror. It might tickle your vagus nerve and make you pee in bed, nocturia. For adults, we don't necessarily wet the bed, but all of our older patients are like, oh, well, I have to go to the bathroom, 2 or 3 times a night. That's not normal. Our bladder has the capacity to hold a lot of fluid. A lot of times as we're getting older, we're getting pudgier and saggier. So I am anyway. I'm working on it.
Oh, let's see.
But as that happens, adults are, why do we snore as we get older? We're getting pudgier and saggier, and our oral airway gets constricted. And so that's why we end up having to go urinate in the middle of the night. Unless you had a lot to drink right before bed, nobody should need to get up to go urinate. Or if you have prostate problems, nobody needs to get up to go urinate. So those are things that we can all be looking for.
Okay, so we know about the oxygen, we know about the nitric oxide. You explained it extremely well.
Thank you.
So then the question is, what do you do about it?
Bring your child to somebody like me that knows their stuff in craniofacial development. Okay. The earlier, the better. Because, it's like some of the parents that come to my office and I want to start treating their 5-year-olds and 6-year-olds with different growth guided appliances. And they're like, well, why don't I just wait? Why don't I just wait till all the adult teeth come in? Well, first of all, most of the craniofacial development is done by the age of 10. And what we're doing around 12 years old when all the adult teeth in is called orthodontic camouflaging. We're just straightening teeth. And if I told you that your son at 5 years old has a mouth breathing issue and has all these possible issues that's setting them up for not to succeed, wouldn't you want to correct it? If I told you your son needed glasses at 5, would you wait till he's 12 to give him glasses? No. You give them glasses at 5 so they can see. You know that they'll need another pair when they're 7, at 9 and 12. You treat it so that they can work and live and have a good life.
Extremely impressive what you do. So let's break it down. Okay, so the parents hear this podcast and they have their child. They know they're either bedwetter or they have night terrors. And so they want to come and see what you can do. They come and also they want to check you out. And I know a lot of adults send the kids first because they want to check you out to see whether they want to go or not. That's just the way the world works.
True.
So step me through the process of what you do for these parents and for these children. Number one, to educate them as to, and you said growth guided appliance. So you're not talking about braces. You're talking about a different thing. You're talking about an appliance that
Correct.
comes in and out and it guides the growth. So if they can't breathe because they're a mouth breather, we know that the jaws don't develop correctly. So the first step is developing the jaw correctly
Correct.
or
First,
guiding that growth.
yes, but identifying what went wrong to begin with is the first part.
So then you have to do a history taking diagnosis and then be able to educate the patient what you learn when you take your scans and stuff. Can you elaborate on that a little bit?
Yes, so when the kids come in, we want to see, do they have a open resting oral posture, meaning are they mouth breathing? If the kids are mouth breathing all the time, we also look at their nostrils and their nose. We want to see, what are the parents' concerns? So we want to make sure that they have the capacity to breathe through their nose. We'll use CBCT imaging, which is the 3D imaging, so that we can check what's going on in the nostrils, the septum, and the adenoid tissue. These are all 3 areas that can cause obstructions, as well as sinuses. So we look at the nose that way. And then that same imaging also lets us check how small their jaws are. Like how much are they lagging for their adult teeth to come in, how narrow their jaws are. So we use the imaging, and then we also use something called a rhino nanometer, and it measures airway resistance on inspiration and expiration, as well as the flow in the nose. So you literally put like a little sponge in one nostril, and the child just breathes, so we can measure it. Nothing scary, nothing terrifying. So it's really important for us to see what the issues are with the airway first.
So
And
I'm fascinated by the imaging. Uh, it came out too late for me to spend $150,000, whatever it is on, because of my age. But I want the listeners to know that when she said 3D imaging, that she's talking about having, you can go and dissect the body all the way through from left to right. You can start at the ear and go all the way through everything, through the brain, through the sinus, through the palate, to the turbinates in the nose. You can go through everything to
it's
be able to
great.
come up with that information
Mhm,
that will, number one, educate the patients. Oh my God, I didn't know that. That's just unbelievable.
mhm.
And then the second thing, it guides you in your treatment
Correct.
because you said it is a guided growth appliance, but you got to have an endpoint to guide to.
Correct.
And because of your education and everything else, you are going to know what that endpoint is. You're not guessing.
Correct. Correct. And that's the handicap that a lot of other doctors don't have. Almost nobody is using 3D imaging to look at the kid's anatomy and measure out how much development they need. So using the technology, we are isolating where the obstructions are. So we start working on them breathing right, correcting the habits. Okay, so this is a lifetime thing. But then we also use the same technology to measure out how narrow their jaws are already developing and how we need to expand or develop it. A lot of people call them expanders, but what we're using is these growth guided appliances. So let's say, for example, I see a 5-year-old and we measure things out. We're already working on habits, but structurally, I need to start helping their jaws develop better. So let's say, for example, I'm measuring out their adult teeth, which you can't even see because they're not going to come out in the cavity yet for another year and a half. But I don't want them to come out in a bad position or an ectopic position, we call it that. I want them to drop in naturally in their right position. So I measure out they need, let's say, for example, a centimeter of space at that time. We make appliances. It could be upper, it could be lower, sometimes both. And they start expanding the jaw. And then we exhaust the appliance. Usually they'll be in it anywhere from like 5 to 8 months. And then we take another image to see, okay, beautiful. This is where they are now. Will they need more? Pause for a minute, let the body adapt, let them work on proper tongue posture, make sure they're breathing through their nose correctly, and then reassess, measure again, see what else we need. Because if they're coming super constricted, they're going to need multiple appliances.
Sure. Yeah.
It's not just one size fits all or one appliance. Everyone's like, do you make this DNA? Do you do an ALF? There's a ton of different appliances that guide the children's growth. It has to be unique to what that child needs, and you need the imaging to help determine that.
So one thing I really want to point out is that sleep apnea now, sleep centers and stuff are catching on. People are understanding how important apnea is, and it's been around long enough to know that the public knows if I go to a sleep center, they're going to wake me up in the middle of the night. They're going to put a CPAP on me,
Yep.
and
That's your
because
anatomy. Just slap on a mask,
it
right?
just pump oxygen down your throat. That's what's literally happening. And of course, there's dental appliances, but we won't get into that to take place of the CPAP. But you have one chance for your child to have their growth guided, not only functionally to live, to breathe, to have a normal life, but also when the form is right, it's going to be beautiful. The face is going to be beautiful.
Right.
So it's imperative that these adults, if you're listening and if you have TMD yourself, then your genetics more than likely that you got a child that may have the same constricted throat and upper and lower jaws. I mean, how wonderful opportunity it is for them to have to come see you and to not only experience this, but to know that you're right, to be able to look at those 3D scans and see that Dr. Pam Morsban is right in what she's doing, and she's going to take care of my child. You can't get any better than that.
Thank you, Mac. And what you said hits home so hard to all these TMD listeners, all the people you treated, everyone listening or watching right now, you adults who suffer. If you were given the opportunity as a child to never to have gone through what you have, what would you have paid?
Yeah,
What would
yeah.
you have paid?
And if you don't have pain, your teeth will be destroyed if all the things that you fix are not fixed. If everything is constricted and this jaw is flapping and chewing and grinding and everything else, it's going to start destroying teeth and not have any TMD pain.
Right.
So there's only one time to prevent that, and that's to go see Dr. Pam Morrisban. Or would you call yourself an airway functional dentist? What would you, somebody may not be able to come to see you. So where would they look? What kind of description would they be looking for? Airway orthodontist? I mean, what do you recommend? I mean, there's no set guideline for us to go by.
Right.
And thank God we all meet like-minded dentists like us with ICMO. We meet and we discussed these things. And it was a wonderful seminar to learn new stuff. But if your dentist is not learning the stuff that you know with the kids and I know with adults, you got to find somebody that does. You can't, this is not a hit and miss thing. You got to be absolutely sure you're going to the right person.
Exactly. I think I'm looking for doctors now that are presenting themselves as airway focused, whether it's airway orthodontist or airway focused general dentist. That's key. And then all you listeners, if you've listened to our other podcasts or watched, again, they need to have the right equipment and training. They need to be talking about the children's airway. If they're not, and they're just talking about Invisalign, you're talking about, orthodontic camouflaging. So you're not talking the same thing. Be aware of that. Or anybody that tells you wait till they get a little bit bigger, their jaws and face grows. No, by the age of 10, 90% of that action's done. Your big teeth are coming into a small body and you're going to have retruded faces. So, the younger to me, the better. I would like to avoid braces completely.
So would you say that the number one equipment that's necessary for you to do what you do is a 3D scanner?
I would never practice without it again. Absolutely.
Okay. So I never had a 3D. I had a 2D. A 2D is just that, is two-dimensional.
Hmm.
3D is three-dimensional. You get to see everything. And
Correct.
it's fascinating. It's a fascinating piece of equipment. So anything else you would like to impart?
Nope, just refocus, start them young. You bend a tree when they're a sapling, right? It's the best
That's
time.
right. So this podcast is on Podbeam, and we would like for everybody to please sign up so that we come out with another session that you'll be notified, and also to our YouTube channel. So when you go to our YouTube channel open up, please subscribe.
Please do. We look forward to hearing from you.
Yes.